So, imagine a sleeper agent.
Right.
We usually picture an attack as, I don't know, something loud and violent.
Yeah, absolutely. Like alarms blaring, windows shattering, that sort of thing.
Exactly, an immediate and obvious breach. But a truly dangerous sleeper agent, they don't break a single window.
Yeah.
They slip in through a microscopic vulnerability you didn't even know existed.
Right.
And once they're inside the building, they do absolutely nothing to draw attention to themselves. I mean, they just wait. They map the ventilation, they copy the security codes, they quietly multiply their forces in the shadows for weeks, sometimes months.
Just completely flying under the radar.
Exactly.
Yeah.
You go about your normal routine, completely oblivious to the fact you've already been entirely compromised.
Yeah.
And then, without any obvious trigger,
stealth invasion that culminates in an overwhelming systemic attack. That is the biological signature of a pathogen that has spent millennia adapting to the human immune system. We're dealing with an organism that weaponizes its own fragility to, fly under the radar.
Well, welcome to the deep dive. Whether you're actively navigating medical board exams, or you're just someone fascinated by the intersection of microbiology and human history, or maybe you're just genuinely curious about how microscopic invaders manage to dismantle our incredibly complex biological defenses, you are in the right place.
Glad to be here.
Our mission today is to thoroughly dissect a multifaceted medical board exam question. But, we aren't just looking for a letter answer. We're using this specific clinical scenario as a gateway to decode the behavior of one of history's most notorious, deceptive, and enduring pathogens.
And we are, of course, talking about Treponema pallidum.
Right, the bacterium responsible for syphilis. And our specific target for this deep dive is mastering the disease's explosive secondary phase.
Yeah, and to truly grasp this, we have to look far beyond a simple list of symptoms, because rote memorization will really only get you so far before this disease tricks you.
It's sneaky.
It is incredibly sneaky. To understand the genius of how this pathogen operates, we need to weave together the epidemiology, the microscopic anatomy of human blood vessels, the historical context of its treatment, and even insights from veterinary science.
Wow, veterinary science too.
Oh yeah. When we connect those dots, a seemingly random and bizarre clinical presentation of the disease suddenly makes terrifying mechanical sense.
Okay, so let's lay the groundwork here. We have a classic 2006 few-mark dermatology board exam question anchoring the discussion today. So I'll read the setup and the options, and I invite you, the listener, to analyze the clues right alongside us.
Sounds good.
So the prompt is to find the exception format, which means 3 of these statements are absolute clinical truths, and 1 is a dangerous misconception. The question reads, quote, all statements regarding syphilis are correct, except, end quote.
A classic trap format.
Right, totally. So here are the 4 suspects. Option A, palms and soles are frequently involved in secondary syphilis. Option B, lymphadenopathy, seen in secondary syphilis, is generally mild, asymmetrical, and painful.
Okay.
Option C, mucosal lesions occur in secondary syphilis and are extremely infectious. And finally, option D, approximately 1/3 of patients who come into cutaneous or mucosal contact with a recent syphilis lesion will become infected.
I love this question. It's an elegantly designed question because it forces the clinician to evaluate 4 entirely different domains of the disease simultaneously.
Right.
You have to evaluate a highly specific dermatological sign, the anatomical characteristics of the lymphatic response, the biological hazard level of mucous membrane lesions, and the raw epidemiological transmission data all at once.
It's a lot. And looking at these options, option B instantly sets off alarm bells for me just based on the language. Well, it describes the lymph nodes, the lymphadenopathy, using 3 very strict qualifiers: mild, asymmetrical, and painful. Usually when a clinical scenario stacks that many specific adjectives, it's a trap.
That's a good instinct.
But on the other hand, it plays directly into our daily lived experience, right? If I get a severe strep throat, the lymph nodes right under my jaw swell up visibly, and they hurt immensely just from me swallowing or turning my head. So painful swollen glands seem like a universal indicator of infection.
And the exam writers are intentionally weaponizing that common sense assumption. They want you to map your experience with a common acute respiratory infection onto a systemic spearhead infection.
Oh.
And that is exactly why option B is the incorrect statement. It's the exception we're looking for.
Okay, meaning the swollen lymph nodes in secondary syphilis are not mild, they're not asymmetrical, and they definitely do not hurt.
Exactly. The clinical reality is actually the exact opposite of that statement. According to the foundational treatises of infectious disease, the lymphadenopathy characteristic of secondary syphilis is generalized, symmetrical, and profoundly painless.
Profoundly painless.
Yes. We are talking about nodes with a distinct, rubbery, elastic consistency popping up in multiple lymphatic chains simultaneously across both sides of the body. You'll find them enlarged in the cervical chain of the neck, the axillary region under the arms, the inguinal region in the groin, and classically the epitrochlear nodes right above the elbows.
And all of them don't hurt.
All bilaterally enlarged and all completely non-tender to palpation.
I really want to pull on this thread because the mechanics of pain here are fascinating to me. Pain in a swollen lymph node is usually caused by the physical stretching of the node's outer capsule, right? So if you have a localized infection, say a bacterial infection in a cut on your finger, neutrophils and fluid rush into the nearest lymph node in the armpit. That rapid acute influx of pus and inflammatory fluid stretches the fibrous capsule surrounding the node very quickly.
And that rapid stretching is key.
Right, because the capsule is packed with sensory nerve endings, so that rapid stretching registers as acute pain. So my question is, if Treponema pallidum is causing nodes all over the entire body to swell up, why aren't all those capsules stretching and causing massive whole body pain?
Well, that is the crucial mechanical difference between an acute localized pyogenic infection, which means pus forming, and the stealthy systemic spread of the specific spearhead.
Okay.
In secondary syphilis, the swelling is not caused by a sudden violent rush of destructive neutrophils creating an abscess. By the time secondary syphilis manifests, the bacteria have already disseminated hematogenously, meaning through the bloodstream to literally every corner of the body.
They're everywhere.
Everywhere. The bacterial load is astronomical. The immune system is responding globally, but it's a cellular response primarily driven by lymphocytes and macrophages, slowly proliferating within the nodes to mount a systemic defense.
Oh, I get it. So it's a slow, steady buildup rather than a sudden explosion. The capsule stretches gradually, accommodating the extra volume of immune cells without violently triggering the pain receptors.
Precisely. The enemy is everywhere equally, so the nodes swell symmetrically. But the bacteria itself lacks the potent surface toxins that cause immediate agonizing tissue necrosis.
So no sudden damage.
Right. It triggers a massive yet mechanically gentle architectural expansion of the lymph nodes. Clinically speaking, this is a massive diagnostic pivot point. If a patient presents with a suspicious rash and generalized lymph nodes, but those nodes are acutely painful, hot, and tender, the clinician must immediately broaden their differential.
Because pain means a different mechanism is at play.
Right. It suggests either a secondary bacterial superinfection on top of the syphilis or a different primary pathology entirely.
Like what?
Well, for instance, Haemophilus ducreyi causes chancroid, another sexually transmitted infection, which is famous for causing suppurative, incredibly painful, rupturing lymph nodes in the groin. The total absence of pain and the generalized swelling of secondary syphilis is what we call a hallmark clinical feature.
Wow. Okay, so that establishes the diagnostic reality, but we really need to step back and look at the broader epidemiological reality. To truly understand this disease, we have to recognize that the clinic is sovereign, and we need to define exactly what we are up against.
Absolutely.
So syphilis is a chronic, systemic, sexually transmitted infection that operates in distinct stages. It alternates between these dramatic, explosive clinical presentations and long periods of total silent latency.
Yes, very long periods of silence.
And looking at the public health data in our sources, the most jarring realization is that this is not a historical artifact. People often relegate syphilis to the Victorian era, picturing out-of-date medical textbooks and long-gone epidemics.
It's a common misconception.
But the numbers tell a completely different modern story. We are seeing a worldwide resurgence regimens, with a particularly steep and alarming increase in cases over the last decade among young populations.
Yeah, the epidemiological curve is unfortunately moving in the wrong direction globally. The data highlights regions like Brazil, where public health systems are battling a severe resurgence.
Right.
And the most tragic consequence of this rising tide is the parallel increase in congenital syphilis. This occurs when an infected pregnant woman passes the spirochete across the placenta to the developing fetus.
Which is just devastating.
It really is. It can lead to devastating outcomes like stillbirth, severe skeletal deformities, and profound neurological damage. It requires absolute vigilance in primary care networks, prenatal screening, and specialized care units.
And the risk factors driving this are rooted in behavioral and social dynamics, right? Unprotected sexual contact, multiple partners, and a lack of access to regular STI screening. Interestingly, the literature also notes that the presence of other STIs creates a biological gateway.
Yes, that's a key point.
Like an existing inflammatory lesion from herpes, for example, creates a massive vulnerable entry point for our specific culprit.
Exactly.
Let's dissect the biology of the culprit itself, Treponema pallidum, specifically the subspecies pallidum. I find the physical structure of this bacterium to be completely bizarre. I mean, it's a spearhead. It looks like a microscopic, tightly wound corkscrew.
It does.
And unlike most bacteria that use external tails or flagella to swim around like tadpoles, the spearhead has its flagella wrapped inside its own outer membrane. They're called endoflagella.
Right, endoflagella.
When those internal motors spin, the entire body of the bacterium twists, allowing it to literally drill its way through dense human tissue and viscous fluids like a living screw.
The motility of the organism is, well, it's a masterpiece of evolutionary engineering, but it is paired with a staggering biological vulnerability.
How so?
Well, Treponema pallidum has an incredibly tiny reduced genome, roughly 1.14 megabases. Over evolutionary time, it has discarded the genetic blueprints required to manufacture most of its own essential nutrients.
It just threw them away.
Pretty much. It lacks the genes for a complete tricarboxylic acid cycle. It cannot synthesize its own amino acids, fatty acids, or nucleotides.
So it has essentially stripped away everything except the bare essentials needed to move, hide, and steal.
Yeah.
I mean, it is the ultimate biological parasite. It relies entirely on the host's cellular machinery to provide the building blocks of life.
Which is exactly why it is so incredibly fragile outside the human body.
Yeah.
It cannot survive exposure to room temperature, drying out, or standard disinfectants for more than a few minutes.
Wow.
It cannot even be reliably cultivated on standard agar plates in a laboratory. It demands the specific, warm, nutrient-rich, microaerophilic environment of human tissue to exist.
That's wild.
And yet, once it breaches the physical barrier of the skin or mucous membrane through a microscopic abrasion during intimate contact, it moves with astonishing, relentless speed.
Okay, so we're entering the realm of pathophysiology now. How fast is, astonishing speed?
From the moment it crosses that initial microabrasion, it gains access to the lymphatic channels and microvasculature. It disseminates hematogenously to the central nervous system, the liver, the joints, and the entire skin surface in a matter of hours.
Hours, that's it.
Just hours. Long before the patient ever notices the very first symptom, which is typically the painless, indurated ulcer known as a chancre that defines primary syphilis, the organism has already secured its systemic foothold.
This timeline is where the sleeper agent analogy really solidifies for me. The initial chancre appears at the site of entry, lingers for a few weeks, and then completely heals on its own without any treatment.
Right, so the patient thinks they're fine.
Exactly. The patient assumes it was just a minor resolving sore. But beneath the surface, the spearheads are multiplying exponentially. Weeks or even months pass in total silence. Then the hematogenous dissemination erupts into the secondary phase.
And it's a massive eruption.
The massive systemic bacterial load triggers a generalized inflammatory storm, shattering the patient's immunological homeostasis. This manifests as profound malaise, low-grade fever, muscle aches, and the highly characteristic dermatological rashes.
Yes.
But I want to know the exact mechanical cause of the rash. The spearheads are everywhere in the blood, sure, but how does that translate into thousands of distinct lesions popping up on the skin?
To understand the rash, we have to look closely at the microscopic battleground where the disease does its most fundamental damage, and that's the endothelium.
The lining of the blood vessel.
Exactly. The endothelium is the delicate, single-cell thick layer that lines the entire interior surface of your vascular system. Treponema pallidum has a profound specific affinity for these endothelial cells. As the spearheads circulate, they physically adhere to the walls of the small blood vessels and capillaries.
So they anchor themselves inside the plumbing of the body.
Yes, they do. And the immune system eventually detects their presence. The local interaction between the adhering spirochetes and the host immune cells triggers an intense inflammatory cascade.
Okay.
The endothelial cells react to this inflammation by proliferating. They multiply and physically swell inward toward the center of the blood vessel.
Wait, if the cells lining a microscopic tube start swelling inward, they're going to completely block the tube.
That is the exact mechanism. As they swell, they choke off the lumen, the central opening of the vessel. This specific pathological process is termed endarteritis obliterans, literally the inflammation of the inner lining of an artery that obliterates the opening.
Wow.
This is the fundamental unifying histopathological lesion of syphilis across almost all tissues.
And when you choke off a blood vessel, the tissue downstream starves.
Exactly. You get localized ischemia, a restriction in blood supply leading to a shortage of oxygen and nutrients. When you combine that microischemia with the intense perivascular inflammation, the swarm of lymphocytes and plasma cells gathering tightly around the outside of the dying vessel, you get focal tissue damage.
Right.
This microscopic event is happening simultaneously in thousands of capillaries across the dermis. The skin is essentially erupting in thousands of tiny, localized areas of vascular strangulation. That is what creates the vast polymorphic array of skin lesions we see in secondary syphilis.
That perfectly sets up option A from the few mark question, which stated that palms and soles are frequently involved. We know this is a correct statement, but from an anatomical perspective, it feels counterintuitive to me.
Why is that?
Well, if the blood vessels are being choked off everywhere, why do the lesions on the palms of the hands and the soles of the feet look so uniquely different? And why are they considered such a massive diagnostic clue? I mean, most common viral rashes like measles or rubella, they start on the face or trunk and often spare the palms entirely.
That's a great observation. You have to apply an anatomotopographic approach to make sense of it. The skin on the palms and soles is structurally distinct from the skin on the rest of your body.
Right.
The epidermis there features a massively thickened, highly keratinized outermost layer called the stratum corneum.
Right, it's the tough, callous protective layer designed to handle walking and gripping.
Precisely. When endarteritis obliterans occurs in the small dermal vessels deep beneath the palms and soles, the resulting inflammatory infiltrate, the fluid, and the proliferating spirochetes are physically trapped.
So they can't get out.
Exactly. They cannot easily migrate upward or break through that dense, thick stratum corneum like they can through the thinner skin on the chest or back.
So the anatomy of the host physically shapes the presentation of the disease.
It forces the lesion to expand laterally beneath the tough surface, creating the classic presentation: deeply infiltrated, palpable, scaly, copper-colored, or hyperpigmented papules. Historically, this specific morphology, a central lesion surrounded by a thin ring of scaling skin, is referred to in dermatology as the collar of beet.
The collar of beet. And the location also explains another bizarre clinical feature, right? The complete lack of itching.
Yes.
Because the inflammatory battle is happening deep down in the perivascular spaces, trapped under the thick callus. It isn't happening up in the superficial epidermis where the primary sensory nerve endings responsible for the sensation of pruritus, itching are concentrated. So you have a patient covered in a highly visible scaly rash on their hands and feet, and they have absolutely no desire to scratch it.
Which is a brilliant diagnostic separator. I mean, a generalized, intensely itchy rash on the trunk might point toward a severe drug eruption, contact dermatitis, or a variety of allergic responses. Right. But a non-pruritic, copper-colored, indurated rash localized to the palms and soles. That is a blaring clinical siren. It is a pathognomonic sign.
A pathognomonic sign.
Yes. In clinical medicine, a pathognomonic sign means a characteristic so uniquely and specifically associated with the disease that its mere presence is practically enough to establish the diagnosis on the spot.
It is the ultimate tell. But while the palms and soles are a dead giveaway, the disease still earns its famous historical moniker, the Great Imitator.
Oh, absolutely.
And that is because the rest of the systemic symptoms can mimic a dozen other common ailments. Beyond the classic copper papules, the generalized rash can be incredibly polymorphic. It might present simply as a faint, diffuse macular rash, flat pink or red spots called a syphilitic roseola that looks exactly like a benign viral exanthem or an early presentation of pityriasis rosea.
And the mimicry extends to the hair and the internal organs too. The ischemic vascular damage in the scalp scalp can cause non-scarring, patchy hair loss. We describe it clinically as alopecia in clearings, which gives the patient's hair a distinctly moth-eaten appearance.
Moth-eaten, wow.
Yeah, and because the Syphilis are systemic, they invade the solid organs. A patient might develop syphilitic hepatitis, presenting with elevated liver enzymes and mild jaundice, or immune complex deposition in the kidneys, leading to nephrotic syndrome and protein in the urine.
So if a physician doesn't take the time to do a full physical exam, specifically removing the patient's socks to check the soles of the feet, palpating the lymph nodes for pain, and taking a comprehensive, non-judgmental sexual history, they will easily misdiagnose this as a stubborn viral infection or an autoimmune flare-up.
Happens all the time, unfortunately.
Which leads us directly into the diagnostic approach. Right. If the physical presentation is chameleon, the laboratory has to provide the objective truth. But testing for syphilis is notoriously complex. It isn't as simple as swabbing a throat and looking for strep bacteria.
Not at all.
The strategy relies on a two-tiered system: treponemal tests and non-treponemal tests. Let's break those down, starting with the non-treponemal tests because the biology behind them is genuinely wild. The most common ones are the VDRL and the RPR. And strangely, they don't actually test for the bacteria at all, do they?
They do not. Non-treponemal tests detect biomarkers of the destruction caused by the disease rather than the organism itself.
Okay.
Specifically, they measure the levels of IgG and IgM antibodies that the patient's immune system has generated against a lipid molecule called cardiolipin.
So I always found this fascinating. Cardiolipin is like a phospholipid, right?
Yeah, exactly.
And it is found in the mitochondrial membranes of our own human host cells. But wait, it also happens to be a structural component of the treponema pallidum cellular envelope itself. So when the spear cheek causes that widespread vascular damage, our cells rupture and dump their mitochondrial cardiolipin into the bloodstream. At the same time, the immune system is destroying the bacteria, releasing the cardiolipin. The immune system registers this massive surge of lipids as a sign of tissue trauma and produces antibodies against it.
It is a quantitative marker of active tissue damage and inflammatory fire. We measure the results in dilutions or titers. A low titer, like 1.2 or 1.4, might indicate early or fading disease.
Okay.
But in secondary syphilis, where the hematogenous dissemination is at its absolute peak, the amount of cellular destruction is massive. Consequently, the VDRL titers are extraordinarily high, routinely exceeding 1.32 or 1.64.
So you use the non-treponemal VDRL test to determine how hot the fire is burning. But because cardiolipin can be released by other types of tissue damage like autoimmune diseases or severe viral infections, you can get false positives.
Great, which is why we need the second tier.
That's where the treponemal tests come in, like the FDA ABS or their water and rapid treponemal immunoassays.
Exactly. Treponemal tests look for antibodies that are exclusively and specifically directed against the unique protein antigens of the treponema pallidum organism itself. They are highly specific confirmatory tests.
Okay.
Once a patient is infected, these treponemal antibodies remain detectable in the blood for the rest of their life, even decades after they have been successfully cured. They tell us definitively this patient has encountered this specific bacterium at some point in their life.
So high VDRL titer means active disease and tissue damage, confirmed by a positive specific treponemal test. That seems like a foolproof system.
Usually, yes.
But the sources highlight a massive dangerous loophole in the non-treponemal testing, specifically during the secondary phase, the prozone effect. This is a scenario where the patient is at the absolute highly infectious peak of their disease, but the laboratory test comes back completely negative. How does a test fail when the signal should be at its strongest?
The prozone effect is a paradoxical phenomenon, and it's caused by an absolute sheer overabundance of antibodies. To understand the failure, you have to understand how the test physically works in the lab. The VDRL is a flocculation assay.
Flocculation?
Yes. The lab technician mixes a standardized solution containing cardiolipin antigens with a drop of a patient's serum, which contains the antibodies.
Under normal circumstances, the antibodies in the serum act like molecular bridges, right? One arm of an antibody grabs onto one cardiolipin antigen, and the other arm grabs onto a different antigen. This cross-linking process pulls all the molecules together into large visible clumps.
Right.
The technician looks under the microscope, sees the clumps, and reads the test as positive.
That is the optimal zone of equivalence. But in the explosive secondary phase of syphilis, the patient's immune system has mounted such a gargantuan response that the serum is absolutely saturated with anti-cardiolipin antibodies.
Saturation.
When that serum is dropped onto the test slide, the number of antibodies vastly overwhelmingly outnumbers the available antigens in the test kit.
The analogy that makes this click for me is imagining a crowded doorway during an emergency. Imagine the antigens are the doorway, and the antibodies are a massive crowd of people trying to get through.
That's a good way to look at it.
If a few dozen people walk toward the door, they link up, form a line, and pass through effectively. You see clear organization and connection. But if 2,000 panicked people sprint at a standard single doorway at the exact same millisecond, they all wedge themselves into the frame simultaneously.
Right, a total logjam.
The physical pressure of everyone trying to connect at once means nobody can move. They can't link arms, they can't organize. If you look at the doorway from a distance, it looks like a solid, unmoving wall. It looks like nothing is happening.
It is an issue of steric hindrance. Every single individual cardiolipin antigen is instantly surrounded and coated by its own dense swarm of individual antibodies. Because the antigens are totally isolated by this swarm, there are no open binding sites left for the antibodies to form bridges between different antigens.
Wow.
No cross-linking can occur. Without cross-linking, the massive visible clumps never form. The technician looks at the smooth, unclumped slide and falsely reports the test as non-reactive.
It is terrifying because the clinician receives a piece of paper saying the patient is negative, when in reality, the patient is essentially a biological weapon of infection. How does a physician outsmart the prozone trap?
This is where clinical judgment must override laboratory data. If the physician observes the undeniable pathognomonic signs, the painless generalized lymph nodes, the copper collar of Biet on the palms and soles, but the VDRL returns negative, they must suspect the prozone effect.
So what do they do?
The solution is remarkably simple. You tell the lab to dilute the truth out of the sample. By performing serial dilutions of the patient's serum, mixing it with saline to artificially reduce the concentration of antibodies, you eventually thin the crowd out enough to reach that optimal zone.
I see.
Once the antibody to antigen ratio is balanced, the cross-linking occurs, the clumps form, and the massive hidden titer is suddenly revealed.
It perfectly illustrates why the clinic is always sovereign. You treat the patient sitting in front of you, not just the spreadsheet from the lab.
Exactly.
There's one other fascinating diagnostic tool mentioned in our texts: dark field microscopy. We established earlier that the spear shade is incredibly thin. So thin, in fact, that its width is below the resolving power of a standard bright field light microscope. It simply doesn't absorb or block enough light to cast a visible shadow. It's invisible against a bright background.
To visualize the live organism directly from a patient, you must manipulate the physics of the light itself. In dark field microscopy, an opaque disc is placed underneath the condenser lens. This blocks the direct light from shining up through the slide into the eyepiece.
Okay.
Instead, the light is directed from the sides, hitting the specimen at a sharp, oblique angle.
It relies on the Tyndall effect, right? It's the exact same optical physics that allows you to see tiny specks of dust floating in the air when a single beam of sunlight cuts through a dark room. You can't see the dust under normal lighting, but against the black background, the dust particles scatter the angled light rays up into your eye, making them shine brilliantly.
Exactly. When a clinician takes a scraping of serous fluid from an active wet lesion and places it under the dark field microscope, the background is pitch black. The spear shades catch the oblique light and scatter it.
Wow.
The clinician can literally watch the brightly illuminated silvery treponema pallidum organisms rotating on their longitudinal axis, corkscrewing their way across the slide in real time. It provides an immediate, definitive diagnosis right at the point of care.
Taking a sample from an active wet lesion brings us back to the few mark question in option C, which stated, quote, mucosal lesions occur in secondary syphilis and are extremely infectious. We know this is a true statement, but the biological details here are critical for anyone practicing medicine.
They really are.
When the systemic rash of secondary syphilis hits the warm, moist, friction-heavy environments of the mucous membranes, like the oral cavity, the throat, or the anogenital regions, it doesn't form dry, scaly papules. It forms something much more dangerous.
The altered environment changes the morphology of the lesion entirely. We see the development of mucus patches, which are highly macerated, grayish-white, slightly elevated plaques. And more significantly, we see the formation of condyloma latum, or flat condylomas. These tend to erupt in the moist skin folds, particularly the perianal and vulvar regions.
The clinical text put a massive, bold warning sign right here for medical students. They emphasize the absolute necessity of differentiating the condyloma latum of syphilis from condyloma acuminatum. Just based on the names, it's incredibly easy to conflate the two, but clinically and etiologically, they represent entirely different diseases.
The distinction is vital. Condyloma acuminatum is the medical term for classic anogenital warts. These are caused by the human papillomavirus, or HPV. Morphologically, they are characterized by their rough, highly textured surface. They're often described as verrucous or cauliflower-like, with distinct finger-like projections.
Cauliflower-like equals HPV.
Conversely, condyloma latum is a manifestation of secondary treponema pallidum infection. The Latin word latum translates to broad or wide. These lesions are fundamentally flat. They're smooth, broad-based, moist, and often covered in a gray exudate. And the most critical piece of knowledge for any healthcare provider is the biohazard level of that exudate.
The texts state that condyloma latum lesions are positively teeming with a staggering density of live modal spirochetes.
They are arguably the single most infectious lesions produced during the entire course of the disease. The bacterial load on the surface of a flat condyloma is so dense that if a clinician were to palpate the lesion without proper glove protection, the spirochetes could easily penetrate microscopic, invisible fissures in the clinician's own skin, resulting in an occupational transmission.
It is a profound validation of option C, which seamlessly carries us to the final piece of the quiz, option D, addressing the epidemiological reality of that transmission. The statement reads, quote, approximately 1/3 of patients who come into cutaneous or mucosal contact with a recent syphilis lesion will become infected.
This metric represents the attack rate of the pathogen. Extensive contact tracing and epidemiological studies have consistently demonstrated that an uninfected individual having a single, unprotected sexual encounter with a partner who possesses active primary chancres or secondary mucosal lesions like the highly infectious condyloma latum we just detailed faces approximately a 30% risk of contracting the disease.
A 30% attack rate from a single exposure. I mean, it isn't a guaranteed transmission, but playing biological roulette with a 1 in 3 chance is incredibly dangerous. It highlights exactly why aggressive public health intervention, partner notification, and immediate prophylactic treatment of contacts are the absolute cornerstones of breaking the chain of transmission.
Absolutely essential.
Which brings us to the most incredible part of this deep dive. The therapeutic approach. We have spent half an hour outlining a pathogen that stealthily invades the central nervous system, chokes off blood vessels, fundamentally alters immune structures, and causes systemic, highly infectious eruptions. And yet, the medical intervention to stop this biological juggernaut is almost anticlimactic in its simplicity.
It is one of the most enduring, undisputed triumphs in the history of pharmacology. The absolute gold standard treatment for secondary syphilis is penicillin G benzathine. The pharmacological protocol calls for an exact dose of 2.4 million international units, delivered via a deep intramuscular injection, typically into the dense tissue of the gluteal muscle.
One single shot. You administer one painful injection, and it halts the systemic hematogenous spread of the spirochete dead in its tracks.
Just one.
The mechanism of action here is elegant. Penicillin belongs to the beta-lactam class of antibiotics. It works by targeting the bacterial cell wall. Treponema pallidum relies on a mesh-like peptidoglycan structure to maintain its shape and survive the osmotic pressure of the human body.
Right.
Penicillin binds to specific enzymes, penicillin-binding proteins that the bacteria use to weave that mesh together. When penicillin jams the machinery, the bacteria can no longer rebuild their walls. As they try to grow and divide, their compromised walls simply give way, and they burst open and die.
And the specific formulation of benzathine is crucial here. Penicillin G benzathine is highly insoluble in water. When injected into the muscle tissue, it acts as a depot. It creates a physical reservoir of the drug that slowly, continuously dissolves and leaches active penicillin into the bloodstream over a period of weeks.
So it's a slow release.
Yes. This sustained, low-level concentration is perfectly calibrated to hunt down and eradicate every last slowly dividing spirochete hiding in the tissues, achieving complete microbiological cure with a single administration for early-stage disease.
What completely blows my mind is the timeline of resistance. Alexander Fleming discovered penicillin in 1928, and we began mass producing it for clinical use during World War II. For over 80 years, we've been deploying this exact same antibiotic against syphilis.
It's remarkable.
In that same time frame, we have watched helplessly as other bacteria evolved into terrifying drug-resistant superbugs, MRSA, multi-drug-resistant tuberculosis, untreatable strains of gonorrhea. How is it biologically possible that treponema pallidum has not figured out how to beat our oldest weapon?
It speaks to the evolutionary trade-off of its highly reduced genome. While its minimalist genetic blueprint allows it to hide effectively from the innate immune system, it also means it lacks the genetic flexibility, the plasmids, and the mutation rates required to develop countermeasures.
It's trapped by its own simplicity.
Precisely. It cannot suddenly evolve the ability to produce beta-lactamase enzymes to chew up the penicillin, nor can it fundamentally alter its penicillin-binding proteins without compromising its own basic survival. After nearly a century of relentless exposure, the clinical resistance of treponema pallidum to penicillin remains an absolute astounding zero.
Penicillin is the undisputed champion, but clinical medicine requires contingencies. What is the protocol if a patient presents with secondary syphilis, but has a documented severe anaphylactic allergy to penicillin?
For standard non-pregnant adult patients, the primary alternative is a 14-day course of oral doxycycline. Doxycycline attacks the bacteria from a different angle, inhibiting protein synthesis rather than cell wall construction.
Okay.
It is highly effective, but relying on a patient to strictly adhere to a 2-week pill regimen carries a much higher risk of treatment failure compared to the guaranteed delivery of a single intramuscular injection.
And you specifically carved out pregnant patients in that scenario. Why can't a pregnant woman allergic to penicillin just take a doxycycline?
Because the stakes are entirely different. Doxycycline belongs to the tetracycline class, which is strictly contraindicated during pregnancy due to its severe teratogenic effects. It actively disrupts bone development and permanently stains the developing teeth of the fetus. Furthermore, no other alternative antibiotic has proven reliable at reliably crossing the placental barrier in sufficient concentrations to guarantee the eradication of spirochete from the fetal tissues.
Meaning, if you use a backup drug, you might cure the mother, but the baby could still be born with devastating congenital syphilis.
Precisely. Because penicillin is the only guaranteed lifeline for both the mother and the fetus, the clinical guidelines dictate a drastic intervention. A pregnant woman with an active syphilis infection and a severe penicillin allergy must be admitted to a hospital for a highly controlled desensitization protocol.
Wait, they intentionally give her the drug she is allergic to?
Under strict continuous monitoring, yes. She is administered microscopic, incrementally increasing liquid doses of oral penicillin every 15 minutes. The goal is to slowly bind and exhaust the Ig antibodies on her mast cells, essentially overwhelming and temporarily disarming the allergic response machinery without triggering full-blown anaphylaxis.
That is intense.
It is. Once the immune system is temporarily tolerant, she can safely receive the massive curative intramuscular injection. It highlights just how irreplaceable the drug is in this scenario.
Let's assume the patient receives the penicillin. The magic bullet is in their system, the bacteria are dying, the cure is underway, but the sources highlight a deeply dramatic physiological phenomenon that happens next.
Yeah.
You take the ultimate cure, but a few hours later you feel profoundly, violently ill.
We are discussing the Jarisch-Herxheimer reaction. This is an absolutely critical piece of clinical education. Every healthcare provider must warn their patient about this before the needle ever touches the skin, because to the uninformed patient, it looks exactly like a catastrophic allergic reaction.
Walk us through the timeline and the mechanics of a Jarisch-Herxheimer event.
It typically initiates between 2 and 12 hours post-injection and occurs in roughly 50% to 70% of patients treated for secondary syphilis. Remember, at the secondary stage, the patient's blood and tissues are absolutely saturated with an astronomical number of live spirochetes.
Hour 0, the penicillin goes in and starts breaking down the bacterial cell walls.
Correct. As the depot penicillin begins to circulate, it causes millions of these spirachates to lice, they literally burst open simultaneously across the entire body. As they disintegrate, they abruptly dump massive quantities of their internal structural components, specifically highly inflammatory lipoproteins, directly into the patient's bloodstream.
It's an internal toxic spill. The burglar is dead, but the structural debris of their hideout is now floating through the blood.
The patient's innate immune system, primarily the circulating macrophages, detects the sudden massive wave of bacterial debris and sounds the ultimate systemic alarm. They release a tsunami of inflammatory cytokines, primarily tumor necrosis, factor alpha, and interleukin 6. This cytokine storm brutally resets the hypothalamus in the brain.
Hour 6, the patient suddenly develops a spiking fever, violent shivering rigors, severe myalgia, tachycardia, and headaches. And the dermatological symptoms flare up too, right?
Yes. The localized inflammation surrounding the dying spirachates in the skin intensifies dramatically. The faint, barely visible macular rashes suddenly glow bright red, the papules swell and become highly pronounced. To a terrified patient shivering with 102-degree fever and a worsening systemic rash, it perfectly mimics an adverse drug allergy.
But the crucial distinction is that this is not an IgE-mediated histamine response. Their throat isn't closing, they aren't going into anaphylactic shock. They're experiencing the intense physiological turbulence of a massive, rapid biological cleanup.
Exactly. The reaction is self-limiting and inherently benign, usually resolving completely within 24 hours as the liver and kidneys filter out the bacterial debris. Management is purely supportive rest, hydration, and antipyretics like acetaminophen to blunt the fever. The clinician's role is preemptive reassurance. You may feel significantly worse tonight. Do not panic. It is not an allergy. It is the physical sensation of the medication working with overwhelming success.
Stepping back from the clinical mechanics, I want to explore how the understanding of this disease has mirrored the evolution of modern medical science itself. The sources explicitly tie the history of syphilis to 3 different Nobel Prize-winning breakthroughs. It is incredibly rare for a single pathogen to intersect with so many foundational shifts in scientific thought.
It really is unique in that regard.
Let's start with the era before antibiotics, which brings us to Paul Ehrlich, who won the Nobel Prize in Medicine in 1908. To understand the magnitude of his contribution, we have to recognize how barbaric the treatments were before him. For centuries, the primary medical intervention for syphilis was heavy metal poisoning, specifically mercury. Doctors prescribed mercury ointments, mercury vapor fumigations, and oral mercury compounds.
The toxicity was staggering. The treatment regularly induced chronic kidney failure, severe neurological tremors, profound gingivitis, and massive tooth loss. It gave rise to the grim historical aphorism, a night with Venus and a lifetime with Mercury.
Ouch.
Yeah. The underlying philosophy of medicine at the time was essentially a blunt force approach. Poison the patient and hope the disease dies slightly faster than the human host does.
And Paul Ehrlich fundamentally rejected that philosophy. He looked at the way different chemical dyes selectively stained specific types of cells under a microscope, how one dye would color a bacterium blue but leave the surrounding human tissue completely untouched. He hypothesized that if a chemical could selectively bind to a pathogen, perhaps a chemical could be engineered to selectively kill the pathogen without harming the host. He literally coined the term magic bullet.
He essentially conceptualized the foundation of modern targeted chemotherapy. Ehrlich and his colleague Sahachiro Hata undertook a massive systematic brute force screening process. They synthesized and tested hundreds of highly toxic organ arsenic compounds, methodically altering the chemical side chains, injecting them into infected animal models, and logging the results.
They failed hundreds of times, but on their 606th attempt, they found it. Compound 606, which they named salvarsan.
Arsphonine. While it was still a harsh arsenic-based compound that required complex intravenous administration and carried severe side effects, it was exponentially safer than systemic mercury. And more importantly, it was the very first synthetically engineered chemical proven to aggressively and specifically hunt down and kill the spirachet in a living patient. It was an unprecedented paradigm shift in the history of pharmacology.
Ehrlich gave us the first targeted weapon. But another Nobel laureate, Jules Bordet, who won in 1919, gave us the ability to see the invisible enemy. Bordet was a pioneer in immunology, and his work directly led to the non-treponemal blood test we discussed earlier.
Bordet elucidated a spectacularly complex defensive mechanism in human blood known as the complement system. The complement system is a cascading sequence of proteins that circulate in an inactive state. When antibodies bind to a pathogen, they trigger the first protein in this cascade. This sets off a chain reaction like a line of falling dominoes that culminates in the formation of a membrane attack complex, a microscopic pore that physically punches a hole in the target cell, destroying it.
Bordet discovered the biological mechanism, but it was a scientist named August von Wassermann who realized how to exploit Bordet's falling dominoes to create a diagnostic tool. In 1906, Wassermann developed the complement fixation test. He created a lab assay where the visible destruction of indicator cells, usually sheep red blood cells, was tied directly to whether or not the syphilis antibodies had already used up the complement proteins in the patient's serum.
It was a stroke of diagnostic genius. The Wassermann reaction was the first widely adopted serological test for syphilis. For the first time in history, physicians were not entirely reliant on waiting for the horrific physical symptoms of the disease to manifest. They could draw blood, run the complement fixation assay, and identify patients harboring the spirachet during the completely asymptomatic latent phases, allowing for intervention long before the catastrophic cardiovascular or neurological destruction of tertiary syphilis became irreversible.
And the final piece of the Nobel puzzle is, of course, Sir Alexander Fleming, who won in 1945. We all know the story of the serendipitous discovery of the penicillium mold producing an antibacterial zone on a contaminated petri dish. But the translation of that chance observation into the mass-produced, highly purified therapeutic wonder drug during the crucible of World War II gave humanity the ultimate enduring cure that we still rely on today.
Ehrlich theorized the magic bullet, Bordet provided the radar to find the targets, and Fleming ultimately delivered the definitive, perfect weapon. It is a triumphant arc of scientific advancement.
However, our sources also mandate that we confront the reality that the history of syphilis research is not solely a parade of Nobel laureates and triumphs. It is permanently scarred by one of the most egregious systematic violations of human rights and medical ethics in the history of clinical science. I'm speaking about the Tuskegee syphilis study. We're not bringing this up to preach, but to factually report on a historical event that fundamentally altered the landscape of modern epidemiology and medical law.
It is an unavoidable and essential chapter in understanding public health dynamics. Initiated in 1932 by the United States Public Health Service, the Tuskegee study of untreated syphilis in the Negro male enrolled approximately 600 impoverished black men in rural Alabama. The majority of these men had pre-existing latent syphilis infections.
The core premise of the study was observational. The researchers wanted to comprehensively document the natural, uninterrupted progression of the disease to its ultimate fatal conclusion. To achieve this, they built the study on a foundation of absolute deception. The men were never informed of their true diagnosis. They were told they were receiving special free care from the government for a vague ailment called bad blood.
The deception was horrific, but the absolute failure of medical ethics occurred in 1947. By that year, penicillin had become widely available and was established as the undisputed definitive cure for syphilis. Standard medical protocol and basic human decency dictated that the study should be immediately halted and every participant injected with a life-saving antibiotic.
But the researchers intentionally chose not to. They actively conspired to withhold penicillin from the men, going to great lengths to ensure they didn't receive treatment from other clinics or military draft boards. They prolonged the suffering explicitly to continue gathering autopsy data.
The study continued for an astonishing 40 years, only ending in 1972 after a whistleblower exposed it to the national press. As a direct result of this intentional withholding of care, dozens of men died agonizing deaths from tertiary syphilis complications. The disease was needlessly transmitted to spouses, and children were born with congenital syphilis.
The fallout from that exposure fundamentally restructured modern medicine. It directly led to the Belmont Report and the establishment of strict federal laws requiring informed consent and the creation of institutional review boards, IRBs, to oversee and protect human subjects in all clinical research. But the legacy of Tuskegee isn't just about legal regulations. The profound, entirely justified distrust of the medical establishment sown by that study still directly impacts the very epidemiological statistics we discussed at the beginning of the show. It echoes today in healthcare disparities, screening hesitancy, and barriers to treatment within minority communities. The pathogen is destructive, but the failure of the medical system compounded the tragedy exponentially.
It is a stark, permanent reminder that scientific advancement must always be irrevocably tethered to ethical oversight.
Shifting gears from human history, I want to explore a fascinating biological tangent presented in the text. The secrets of the animal kingdom. We spend so much time analyzing human anatomy and human failures. It raises a compelling question. Is Treponema pallidum exclusively a human problem, or are there animals out there suffering from endarteritis obliterans and copper rashes?
The precise subspecies that causes human venereal syphilis, Treponema pallidum, subspecies pallidum, is an obligate human pathogen. We are its only natural reservoir. However, the wider family of treponemes and related spirituettes heavily intersects with the animal kingdom, and studying those connections has been pivotal to our scientific understanding.
The sources specifically mentioned rabbit syphilis.
Yes, Treponema paralus caniculae is a naturally occurring venereal pathogen in rabbits or Autologous cuniculus. It causes crusting, inflammatory lesions on the face and genitals, and is transmitted sexually. But the true intersection with human medicine came from our inability to grow the human spirochete in a lab. Because Treponema pallidum is so metabolically fragile, it simply dies in artificial broth.
You can't just swab it onto an agar plate and put it in an incubator.
Exactly. So for decades, beginning in the early 20th century, the only reliable way microbiologists could maintain living strains of human syphilis for research and drug testing was to cultivate it inside a living mammalian host. Researchers would inject the human spirochete directly into the testicles of laboratory rabbits. The rabbit's immune system provided the perfect microenvironment to keep the bacteria alive and replicating, allowing scientists to harvest the organisms for study. The nickel strain, isolated in 1912 from a patient, was maintained in continuous rabbit passage for almost a century.
The foundation of human serological testing and the validation of penicillin were literally incubated inside rabbit models. The text also briefly mentions dolphins, which seems completely disconnected from a spirochete. How do dolphins fit into the study of STIs?
It connects to the broader epidemiological study of highly social mammals. Bottlenose dolphins naturally contract and spread various strains of genital papillomaviruses, forming complex networks of transmission. Because wild dolphins exhibit intricate, fluid, social, and sexual structures that somewhat mirror human societal dynamics, veterinary epidemiologists study these marine outbreaks. Tracking how a virus moves through a pod provides vital mathematical models for understanding the propagation dynamics of sexually transmitted infections in complex networks, helping us refine our own public health modeling for pathogens like HPV and syphilis.
And finally, the text touches on macaques, the non-human primates in Africa. This points toward the evolutionary origin story of the pathogen.
Recent genetic sequencing of wild baboon and macaque populations in Africa revealed that they naturally harbor treponemal strains that are genetically near identical to the strains that cause Yaz and Basal in humans. Yaz and Basal are non-venereal treponemal diseases transmitted primarily by skin-to-skin contact among children in tropical regions, causing severe bone and skin destruction. The presence of these pathogens in wild primate reservoirs raises intense evolutionary questions. Did the ancestral treponeum originate in primates and jump across the species barrier into humans millennia ago, eventually mutating into the venereal syphilis we battle today? It reminds us that our pathogens are intimately woven into a much larger, ancient biological tapestry.
It is a humbling perspective. We are not fighting these microscopic wars in a vacuum. We are part of a massive, interconnected web of host pathogen evolution. We have covered an immense landscape today. We started with a microscopic swelling of endothelial cells blocking capillaries, journeyed through the biohazardous swamps of mucosal condylomas, navigated the paradoxical prozone laboratory traps, and charted the historical timeline from toxic mercury to the miracle of penicillin. It is time to crystallize this knowledge. Can you provide the ultimate synthesis of what a clinician must prioritize when managing secondary syphilis?
The fundamental takeaway is that secondary syphilis represents the explosive, highly infectious, systemic dissemination of a chronic pathogen. The spirochete has utilized hematogenous spread to invade every organ system, driving widespread vascular inflammation via endarteritis obliterans. The absolute diagnostic pivot point for any clinician is recognizing the physical semiology. You must actively look for and identify the painless, generalized, symmetrical lymphadenopathy and the highly pathognomonic, copper-colored, scaly papules trapped beneath the thick stratum corneum of the palms and soles. Recognizing these specific signs shatters the great imitator camouflage, steering you away from misdiagnosing benign viral rashes or drug allergies. You must confirm the diagnosis, anticipating laboratory phenomena like the prozone effect, and immediately administer the curative dose of penicillin G-benzathine to eradicate the pathogen and sever the epidemiological chain of transmission.
Let me drill down the rapid-fire key points, the concepts that need to be permanently locked into your clinical hard drive. Number 1. The lymph nodes in secondary syphilis are generalized, symmetrical, and completely painless, owing to a cellular immune response rather than acute pyogenic infection. Number 2. The presence of non-itchy, copper-colored papules on the palms and soles is a massive pathognomonic red flag. Number 3. Mucosal lesions, specifically the flat, macerated condyloma latum, are teeming with spirochetes and represent an extreme biological hazard. Number 4. The epidemiological transmission rate from a single unprotected contact with an active lesion is approximately 30%. Number 5. Penicillin G-benzathine remains the undefeated zero-resistance gold standard treatment, relying on a depot effect for sustained eradication. And number 6. You must proactively warn your patients about the gerish hair-timer reaction, the sudden, intense fever and systemic flare-up caused by the massive cytokine response to dying bacteria, so they do not mistake the cure for a catastrophic drug allergy.
For those navigating board exams, precision is everything. Anchor yourself to the P mnemonic. Palms, plantar, papules points directly to secondary syphilis. Always contrast the lymphatic presentation across the disease stages. Primary syphilis features local, painless nodes draining the chancre. Secondary syphilis features generalized, painless nodes everywhere. If a clinical vignette presents you with acutely painful, hot, suppurative lymph nodes in the groin, immediately abandon the syphilis diagnosis and evaluate for secondary bacterial infections or Haemophilus ducreae. Finally, guard against the nomenclature trap. Never confuse the broad, flat, highly infectious condyloma latum of syphilis with the rough, cauliflower-like condyloma acuminatum caused by HPV.
We started this hour discussing a sleeper agent, a fragile, delicate burglar that sneaks in, studies the architecture, multiplies in the dark, and then systematically disables the building from the inside out. Treponema pallidum is biologically stunted. It has a tiny stripped-down genome. It lacks the basic metabolic machinery to survive outside a host for more than a few minutes. It has remained completely laughably defenseless against an antibiotic we discovered almost a century ago. And yet, despite possessing all of these profound, seemingly fatal evolutionary weaknesses, this microscopic organism has successfully evaded complete eradication. It has plagued human civilization for centuries, and today it is driving a renewed, terrifying global epidemiological surge. So here's the final thought I want to leave you with, something to mull over long after this deep dive concludes. If an organism this incredibly fragile and a disease this easily curable can continue to thrive, multiply, and cause massive public health crises year after year, what is the enduring success of this specific bacterium expose about the systemic blind spots, the communication failures, and the deep-seated social inequities embedded within our modern healthcare networks? It forces us to consider the uncomfortable truth. Perhaps the greatest strength of the disease isn't found in its own biology, but rather in its relentless ability to exploit our own human vulnerabilities. Think about that.